The story of gastric ultrasound is the story of gastric content and aspiration risk assessment. In the beginning, the practice of anesthesia used to carry significant complications. Aspiration of gastric contents was responsible for a large proportion of anesthetic-related deaths. The fasting guidelines were developed to decrease aspiration risk, but have several limitations. Despite their use, pulmonary aspiration is associated with severe morbidity and death. In fact, a close claim analysis from 2021 recommended to modify our practice by including gastric content assessment to minimize this risk. Gastric ultrasound is a simple point-of-care ultrasound exam that provides qualitative and quantitative data that can be used to objectively assess gastric content and determine aspiration risk. I'll be referencing the work from Drs. Van de Putte and Dr. Perlas and their website gastricultrasound.org, as well as the ASRA.com newsletter. ShowMeThePocos.com contains cineclips on gastric ultrasound and can be found here by hitting the abdomen tab and then the gastric ultrasound tab. ShowMeThePocos.com also has an algorithm so that you can go step by step if you cannot fully remember what pattern recognition corresponds to what type of gastric content. Plus, it has a built-in calculator that can be used to determine risk when the content is clear fluid if you want to use quantitative measures to estimate risk. Let's dive in. By the end of this lecture, you shall be able to identify or recognize the following. Identify the appropriate ultrasound settings, probe selection, and method of the gastric ultrasound examination. Identify relevant anatomic structures that assist in the appropriate location of the gastric antrum, abdominal aorta, superior mesenteric artery, pancreas, and liver under ultrasound. Identify the expected layers of the gastric antrum based on the ultrasonographic examination. Determine the contents of the stomach by the different ultrasonographic appearances of the gastric antrum: no content, clear secretions, clear fluid, and solid food. Then, determine if the amount of fluid seen on the gastric ultrasound exam represents expected secretions versus clear fluid via a quantitative approach. Make an aspiration risk assessment based on the gastric ultrasound exam performed. Both quantitative and qualitative assessment methods are described. Recognize the limitations of gastric ultrasound for technical or anatomical constraints. Introduction. Perioperative aspiration of gastric contents is a serious complication of anesthesia. This can lead to aspiration pneumonia in the form of chemical pneumonitis, bacterial aspiration pneumonia, or mechanical obstruction. These manifest in severity ranging from hypoxia to acute respiratory distress syndrome and even cardiac arrest and death. Prevention of perioperative pulmonary aspiration is part of the process of the perioperative evaluation and preparation of the patient. In order to mitigate this risk, perioperative fasting guidelines were developed to lower the risk of pulmonary aspiration in patients undergoing surgery. They assist healthcare providers and patients in informing when to stop eating and drinking. They are considered to be the standard of clinical care and evidence-based practice. These guidelines have several limitations. They were developed for otherwise healthy individuals and not intended to be used for patients with coexisting diseases that impair gastric emptying or fluid volume, such as obesity, diabetes, hiatal hernia, ileus, enteral tube feedings, amongst others. These conditions severely limit the applicability of the guidelines to all patients. On the other hand, we also have maneuvers to minimize aspiration risk, including the use of crickered pressure. The usefulness of this technique is debatable, since in up to 50% of the population the esophagus is not behind the trachea and may obscure the view when intubating if too much pressure is applied, thus making it an ineffective measure when performed. Enter the era of gastric ultrasound. Gastric ultrasound is a point-of-care tool for aspiration risk assessment. It can 1. Determine the nature of gastric contents, whether it's empty, clear fluid, thick fluid, or solid, and 2. When clear fluid is present, its volume can be estimated. These are the two main objectives we will try to discern in this lecture: anatomy and physiology. Basic anatomy and physiology of the stomach as it relates to its contents is in order. This is so that we can understand volumes and patient positioning. The stomach can be divided into 5 distinct sections. From proximal to distal, these are cardia, fundus, body, antrum, and pylorus. Healthy individuals frequently have residual volumes of up to 1.5 ml per kilogram that does not typically pose a significant aspiration risk. This value will become important as we shall later explore. As increasing volumes of liquid are ingested, an empty stomach expands to receive it. The gastric antrum increases in size in linear relation to that of the rest of the body of the stomach, up to 300 ml. Volumes in excess of this amount result in only modest further increase in antral size, with larger volumes being accommodated by more proximal areas of the stomach. We also have to remember that the tone of the lower esophageal sphincter and the upper airway reflexes are compromised with sedation and general anesthesia. These protective physiological mechanisms against aspiration are thus abolished, which increases the risk of aspiration. IM framework. It is important to recognize that, like all POCUS applications, gastric ultrasound should follow the indication, acquisition, interpretation, and medical management framework. This allows a standardized approach to minimize errors. Indication. We want to use gastric ultrasound when gastric content is unknown based on the available clinical information. This will be the case in patients with comorbid systemic diseases and in those on medications that can affect gastric emptying. That will also include those patients on glucagon-like polypeptide 1 agonists. Important guidance from the ASA is to hold these types of medications the day of surgery if they are on a daily dose. If they are on a weekly dosing regimen, then they should be held a week prior to surgery. However, these timeframes may change in the future. What is clear is that if these medications have not met their threshold, consider doing a gastric ultrasound to estimate aspiration risk. Other indications for gastric ultrasound include an unconfirmed fasting history, such as the case of an altered mental status, language barrier, or in pediatrics. Acquisition. Let's now look at the acquisition technique for gastric ultrasound. The curvilinear probe with an abdominal preset allows the sonographer to visualize deeper structures at the expense of a worse resolution. However, this is the optimal choice of probe to use to visualize the gastric antrum. Scanning should occur in a parasagittal plane with the probe held perpendicular to the surface of the skin at the level of the epigastrum as seen on this clip. The probe should be looking slightly upwards. It is important to note that this technique may not be accurate for those with an abnormal gastric anatomy, such as gastric resection or bypass, gastric band fundoplication, or large hiatal hernias. Patient positioning is paramount. The patient should be in a semi-sitting position or in the right lateral decubitus position. These two positions are going to be the most sensitive at measuring volume due to gravitational shift. This is opposite to the position you'll be using for a patient having a focused cardiac exam. The idea is to move any fluid that is present in the body of the stomach to expand the gastric antrum. The section of the stomach interrogated should be the gastric antrum. The standard plane or cut made by your ultrasound system should include the left lobe of the liver, the abdominal aorta, and the superior mesenteric artery. If the abdominal aorta is not visualized, the inferior vena cava and the superior mesenteric vein should be visualized. Set your depth at greater than 4 centimeters and make sure your interrogation sector is set to a wide angle. This is the piece of the pie that the ultrasound displays and should be set to wide and not narrow. It is important to note that peristalsis occurs in the gastric antrum, which may have an impact on its size. So record a clip of at least 10 to 15 seconds. 3D model of the gastric antrum. These clips are designed to assist you in understanding the structures related to the stomach and how the ultrasound probe is positioned to provide adequate interrogation of the gastric antrum. In this 3D model, we can appreciate the sector that is cutting on the sagittal plane and through the abdominal aorta. Compare that to what a 2D clip will show and the relevant structures around the gastric antrum. A close-up view of this 2D image shows the gastric antrum and reveals its multiple layers. The gastric wall measures between 4 to 6 millimeters in thickness, with distinct sonographic layers that can be better seen with a linear transducer. The sound waves penetrate the outer layers first, going inwards. It starts with the serosa. This is a thin hyperechoic layer. Then we have the muscularis propria, which is the thickest layer of them all, and it's hypoechoic. Then we have the submucosa, which is a hyperechoic structure. Then we have the muscularis mucosa, which is a thin hypoechoic layer, which may be too small to be seen with a curvilinear probe. Finally, we have the mucosal air interface. This is a hyperechoic layer. In summary, the echogenicity of the stomach wall is a sandwich of alternating echogenicities starting with and ending with hyperechoic layers. Interpretation of gastric ultrasound. Let's now define the nature of gastric content. Empty gastric antrum. Both clips have none to very little content within the walls of the stomach. The gastric antrum wall layers appear thick, with both the anterior and posterior walls being in close proximity to each other. The gastric antrum has a round or oval shape and has a target or bullseye pattern. Full stomach. Let's say you decide to take a bite out of your favorite meal while enjoying this amazing lecture. Despite there being a wide variety of meals, gastric ultrasound has very distinct features. Recent meal. Early on, this is what we appreciate on this clip. Notice that the gastric antrum is distended with a thin anterior wall. Something interesting here is that you cannot see beyond the anterior wall of the stomach and represents an ultrasound artifact. This is acoustic shadowing. As the ultrasound beam penetrates the lining of the stomach, it encounters air mixed with the meal, and thus we cannot appreciate anything deeper. We cannot see beyond the posterior aspect of the gastric antrum and any structure that lies on the far field of this view. This happens because chewing and swallowing involves an air-solid mixture. This is the frosted glass pattern. We can also appreciate this more discrete acoustic shadowing on this second clip. The gastric walls are less distended than the last example, but we see that the gastric antrum is filled with a collection of fluid that appears hyperechoic. In this example, we'll also appreciate a ring-down artifact, as the sound waves hits a fluid collection that is trapped by air bubbles, causing it to resonate and thus emits a continuous signal to the transducer, and the machine interprets there is a hyperechoic structure beyond the posterior wall of the gastric antrum, a few hours after a meal. What we see on the screen is the solid late stage at approximately 2 hours after your meal. The stomach appears distended, with thinner walls and something within. The borders of the stomach wall are no longer obscured by air. The content of the stomach reveals mixed echogenicity. We no longer see acoustic shadowing since there is no air obstructing the view of deeper structures. We now come to our first crossroads on the risk of aspiration from a qualitative point of view. If we see an empty stomach on gastric ultrasound, this is reassuring. If we see signs of a full stomach, this will denote a high aspiration risk. However, more than likely, the most challenging ultrasound finding is that of clear fluid. Clear fluid, normal gastric secretions, as well as any clear liquid with no particulate matter, will appear hypoechoic or black on ultrasound. Multiple floating small air bubbles appear hyperechoic within the sea of blackness and give a starry night appearance, which is what we see on this example. You'll feel thirsty after a whole day in the OR and decide to have a large volume of water, and your gastric antrum begins to distend. The normally thick hypoechoic wall becomes thinned out and round, and this is what we appreciate on this next example. You can also see a fair amount of debris on the posterior aspect of the stomach. Regardless of the amount of fluid accumulated, you can still see what lies beyond the posterior wall of the stomach. In fact, a well-distended gastric antrum will cause acoustic enhancement of the structures that lie beyond, so that they appear brighter as we appreciate here. We mentioned earlier that the normal gastric volume is typically less than 1.5 mL per kilogram. Qualitatively, it may be challenging to determine what you see on the scan is more than this expected baseline secretions threshold. How thin does the wall or how round does the gastric antrum need to be before we consider the stomach to be full of fluid? For this reason, we need to quantify the amount of fluid by using models that approximate the volume of fluid in the stomach, which gets us to the next section of the lecture. Volume measurement for clear fluid. If there is clear fluid in the gastric antrum, it may be necessary to estimate the volume to make a determination regarding aspiration risk. There are various ways of determining the volume of the stomach based on mathematical formulas. While these formulas are excellent at determining risk, it is important to realize that one of the principles of the POCUS exam, as noted in some guidelines, is that no measurement is made. We evaluate the images in a qualitative and semi-quantitative manner only. Despite which caveat, we can have an accurate assessment of volume given by a simple measurement. Gastric volume can be estimated by measuring the cross-sectional area of the gastric antrum. There is a linear correlation between the cross-sectional area of the gastric antrum and gastric fluid volume. The stronger correlation occurs in the RLD position. To do this, we trace the area using the freehand tool on your ultrasound machine and include the full thickness of the gastric wall from serosa to serosa. Alternatively, the cross-sectional area can be estimated by using the formula of the area of the ellipse. Cross-sectional area is equal to pi/4 times the anteroposterior diameter times craniocaudal diameter. These two diameters should be perpendicular to one another. The measurement needs to be taken between gastric contractions to avoid underestimation. We can now determine volume using the following linear model, applicable to adult, non-pregnant patients with a BMI lower than 40. This model uses gastroscopy as the reference standard. This is the formula by Dr. Perlas and her colleagues. If the estimated gastric volume is higher than the 1.5 mL per kilogram baseline secretions, then the aspiration risk is high. This mathematical model can estimate gastric volumes of up to 500 mL. ShowWithThePOCUS.com under the Algorithms tab allows you to plug those numbers into a calculator using the formula above and will give you an estimation of the gastric volume and risk of aspiration as seen here. Notice that the estimated gastric volume is in regards to the total body weight and not lean or ideal body weight. Semi-quantitative volume assessments. There is a myriad of clinical scenarios where making measurements and deriving a volume is simply not possible. In fact, like I mentioned earlier, the POCUS exam should focus on qualitative or semi-quantitative assessments. As it turns out, there is a semi-quantitative grading system to differentiate clear low from high volume states by comparing gastric ultrasound findings in the supine and then performing the scan on the RLD position. A. Grade 0. Empty gastric antrum in both positions. This is suggestive of no gastric content present and represents low aspiration risk. B. Grade 1. Empty gastric antrum in supine, but clear fluid present on the RLD position. This is suggestive of a small amount of gastric content. In this scenario, the amount of fluid in the stomach is estimated to be less than 100 mLs in 75% of the cases. Grade 2. Gastric antrum is distended with hypoechoic fluid in both positions. This is consistent with a high volume state. In this scenario, the amount of fluid in the stomach is more than 100 mLs in 75% of the cases. It would be reasonable to assume that a grade 2 implies higher risk. As you may have noticed, in both grade 1 and 2, we may need to make further calculations to be more precise with the aspiration risk. And in these cases, we may have to estimate the gastric volume using the linear formula as mentioned above. This is so that we can have an accurate assessment of the amount of volume. If the gastric volume is estimated to be less than 1.5 mLs per kilogram, the risk is low, otherwise, the risk is high. Bringing it together. Despite the limitations of the perioperative fasting guidelines, they remain the gold standard, but will likely change in the future in light of the use of point-of-care ultrasound. It is clear that it offers an objective means of assessing and individualizing aspiration risk and to guide management. This is especially important in situations in which the risk is unclear or undetermined. As per Dr. Van de Put and Dr. Perlas, this will be patients who have not followed the fasting guidelines or due to the urgent nature of the clinical situation. It can also be used in those who have delayed gastric emptying, such as those with critical illness, diabetic gastroparesis, etc. Gastric ultrasound can also be used in those who have an unreliable history. Remember that the technique may not be accurate for those with abnormal gastric anatomy, and some patients may have poor gastric ultrasound windows. With regard to the clinical decision making, we encounter the following paths. The gastric antrum that is empty and remains empty despite changes in position implies a low aspiration risk. On the other extreme, we have a gastric antrum that shows solid food either by creating acoustic shadowing or we see a distending gastric antrum full of various degrees of echogenic material. We do not technically need to change scanning position if we appreciate this and implies a high aspiration risk. Finally, we have clear fluid. If we see grade 1 or 2, we would need to make estimates of volume to estimate risk. A volume that is estimated to be above 1.5 mLs per kilogram is considered to be high. It is likely that in the acute setting, anything other than a grade 0 would classify as high risk due to time constraints. Well done. We are done with gastric ultrasound. Off to your next lecture.